All right, so today I want to start talking about the axilla, which is an area that you started to dissect on Tuesday. Um, Many of you did progress pretty far and actually start getting down into the structures of the axilla, but it's a very confusing area, so you probably didn't start making heads or tails of anything that you were looking at. You may have seen a lot of stuff, but not been able to identify it. So hopefully after today's lecture, you'll have a little bit easier time actually identifying the structures, and you should try to find all of these things today in lab. So first of all, the axilla is an anatomic space that lies between the pectoralis muscles on the front of the chest, the rib cage and the intercostal muscles that actually form the chest wall. It's posterior and inferior to the clavicle, and this space also lies anterior to the scapula and the muscles on the surface of the scapula, such as the subscapularis muscle. So here you can see all of the structures that define the boundaries of the axilla. So you can see pectoralis major that's been cut and reflected medially, pectoralis minor also cut off of its insertion on the coracoid and reflected medially as well. You need to cut those structures in order to actually see into the axilla. In your case, in your dissection, you actually detach the pec major from its origin and reflected it laterally, so a little bit different from what's shown here. Same thing with pec minor. You detach the pectoralis minor from its origin on ribs 3, 4, and 5 and reflected it superiorly. But still, you have to cut those muscles in order to actually see into the axilla. And then you can see there is actually space there that sits lateral to the wall of the thorax, the ribs and the intercostal muscles, partially posterior to the clavicle. You can think of the axilla as being almost like a pyramid structure, with the point of the pyramid extending up posterior to the clavicle, extending all the way up into the neck. And then the posterior wall of that pyramid, the posterior wall of this space is made up of the scapula and the subscapularis muscle, which sits on the anterior surface of the scapula. The axilla also has a base or a floor. So again, using that pyramid analogy, imagine the base of the pyramid actually resting on the ground. The base of the pyramid would actually be the skin of your armpit. So the axilla extends down to the skin that forms the armpit between the arm and the chest wall. These boundaries are a little bit easier to understand if you look at a cross-sectional view of the axilla. So the next slide is a horizontal or axial cross-section through the axilla. And maybe now it's easier to visualize this space lying between these different structures. So I'm going to get my little drawing tools here. So the axilla has an anterior wall or anterior boundary formed by the pectoralis major and pectoralis minor muscles. Those are the ones I said we have to reflect out of the way in order to be able to see into this space. The medial wall or medial boundary is formed by the ribs and the intercostal muscles that lie between the ribs, but also the serratus anterior muscle that originates from those ribs and lines the whole side of the rib cage, extending all the way around to the back to insert on the medial border of the scapula back here. The posterior wall of the axilla is formed by the scapula itself, as well as the subscapularis muscle that lies on the anterior surface of the scapula. And also, if you continue out laterally a little bit, the muscles like the latissimus dorsi and teres major also contribute a little bit to the posterior wall of the axilla. And if you look at the anterior wall formed by things like pec major, and then the posterior wall formed by subscapularis, teres major, latissimus dorsi, you can see how those anterior and posterior walls kind of converge onto their insertion into the humerus. So you've got pec major inserting into the intertubercular groove, you've got latissimus dorsi and teres major all inserting into that intertubercular groove of the humerus. So the anterior posterior walls of the axilla converge at that point. The structures that are found within the axilla are very important because they provide the entire blood supply and the entire nerve supply to the structures of the upper limb. So within the axilla, you find the axillary artery, shown here in red, the axillary vein, which is actually not drawn right. I drew this picture and I didn't really draw it right. The axillary vein actually sits more in an anterior position in front of the artery. And then the three yellow ovals represent the major structures of the brachial plexus, this network of nerves that gives rise to all of the nerves of the upper limb. The rest of the axilla is filled in with a whole lot of fat and a lot of lymph nodes. And you may or may not see the lymph nodes during your dissection. If you do see them, they usually just look kind of like little gray blobs, like little gray kidney beans. Oops. So going back to this anterior view of the axilla, now you can identify those contents that we just talked about. The axillary vein has been cut away in this particular view. And when you do the dissection this afternoon, I recommend that you just go ahead and remove any veins because they're just going to be in the way. You can see the axillary artery, and the axillary artery has a number of branches that we're going to talk about today. And then the axillary artery is surrounded by the different components of the brachial plexus, the different nerves that make up the brachial plexus. So let's start off by talking about the arteries that are going to be found in this area, the arteries within the shoulder region and specifically within the axilla. So let's just start off with a general overview, tracing the flow of blood from the heart up into this area. So you've got blood that is oxygenated by the lungs and comes back to the heart through the pulmonary veins and eventually ends up in the left ventricle of the heart. So all of the oxygenated blood in the body is in the left ventricle of the heart, and then it flows up into the aorta, and the aorta makes an arch and arches over, and then eventually continues back down through the thorax and abdomen. But coming off of the aortic arch are three major branches. There's an artery called the brachiocephalic artery, which is present only on the right side of the body. You only have a right brachiocephalic artery. You never have a, well, I shouldn't say never because there are rare exceptions, but most of the time there's no left brachiocephalic artery. So it's only found on the right side. That brachiocephalic artery on the right then splits into the right common carotid artery, bringing blood up towards the head and neck, and then the right subclavian artery heading over towards the axilla and ultimately towards the upper limb. On the left side of the body, the common carotid and subclavian arteries branch directly off the aortic arch. So that's why they're never combined together, or usually not combined together, forming a left brachiocephalic. So you have a left common carotid also bringing blood up towards the head and neck, and then a left subclavian artery heading towards the axilla. If you look down at the bottom of the slide, you can see a close-up of the subclavian artery as it comes up off of the aorta and comes out of the thorax and leaves the thorax and crosses over the first rib as it exits the thorax. This is the point where the subclavian artery changes names to become the axillary artery. So right at the point where that artery passes the edge of the first rib, right here, that's what that black line indicates, the artery changes names from subclavian to axillary. And then it continues as the axillary artery all the way down to this point. And I'll be honest, this is one of Netter's drawings, and it's not one of my favorites because there's some issues with it. He put a little line down here to indicate the end of the axillary artery and where it changes names to become brachial. But in reality, it should be a lot lower. It should be down here because the axillary artery changes to become brachial artery right at the inferior border of the teres major muscle, which would be right about here. So he put that black line a little too high up. So we've got one continuous vessel, but it has three different names depending on where it is. So it's subclavian, crosses the edge of the first rib, becomes axillary, and then when it passes by the inferior border of teres major muscle, then it becomes the brachial artery. The axillary artery is the part that's actually sitting within the axilla, so that's what we're going to focus on. Now notice these numbers on here, 1, 2, and 3. The axillary artery is further subdivided into 3 sections. And there's really no significance to these different sections. It's just for convenience. You'll see why in a minute, why it's kind of useful to have these divisions. Once again, Netter didn't paint this very well because the 3 divisions are based on the location of the pectoralis minor muscle. Let me explain that, and I'll tell you where Netter kind of screwed up on this one. So the first part of the axillary artery, identified by the number 1 here, is the part of the axillary artery that lies proximal to or medial to the pectoralis minor. So before the artery reaches the pectoralis minor. The second part is the part of the artery that lies posterior to the pectoralis minor. So try to picture the pectoralis minor sitting in its anatomic position. This part of the artery would lie immediately posterior to the muscle. And then the third part of the axillary artery would lie lateral to or distal to, beyond the pectoralis minor. I'm going to change colors here so I can draw something else in. So where Netter kind of screwed up is that the pectoralis minor originates from ribs 3, 4, and 5, and has its insertion here on the tip of the coracoid process of the scapula. So the pectoralis minor would be sitting about like so. That should be the second part of the axillary artery, the part that lies immediately posterior to that pectoralis minor muscle. So the third part should actually be down here. That doesn't look like a 3, but the third part should actually be down there, lateral to or beyond the pec minor. The reason that this distinction between the first, second, and third parts is useful is because you can use it as a landmark to help you identify the branches of the axillary artery. And it just so happens that there's a nice pattern here that the first part of the axillary artery has 1 branch, the second part has 2 branches, and the third part has 3 branches. So let's, whoops. Getting my drawing tool again. So let's take a look at the branches off of the different parts of the axillary artery. So the only branch off of the first part of the axillary artery is called superior thoracic artery, or occasionally you'll see it written as supreme thoracic artery. This is a very tiny little branch. It's usually not as big as Netter shows it here, and it's just supplying a little bit of blood to the first couple of intercostal spaces. Moving into the second part, as I said, there are 2 branches from the second part. The first of these is called the thoracoacromial artery. And the thoracoacromial artery itself can be very, very short. It very quickly splits up into a whole bunch of branches traveling to different areas in the shoulder region. Some may be traveling towards the chest wall. There's one branch usually going to the clavicle, another branch going out to the acromion, and another branch traveling over to the deltoid muscle. So the thoracoacromial, like I said, is very short. Sometimes the only way to identify it is to look for all of these little branches and trace those branches back to one common trunk that should be coming off the second part of the axillary artery. The next branch off of the second part, remember I said there are 2 branches, this is called the lateral thoracic artery. And there are a couple different ways to identify this. For one thing, it should be a branch from the second part, so that alone is a kind of a landmark to help you identify it. But if you follow the lateral thoracic artery down, it should be lying more or less right along the lateral border of the pectoralis minor muscle. So if you imagine that pectoralis minor muscle, over in this area, that lateral thoracic artery should be running right along the edge of that pec minor muscle. The third part of the axillary artery has 3 branches, or at least initially has 3 branches. One of those subdivides again later. The branches labeled G here are the anterior and posterior circumflex humeral arteries. The anterior circumflex humeral artery is usually smaller. It gets its name from the fact that it wraps around the shaft of the humerus. So a circumflex artery is any artery that wraps around something. And there's a whole bunch of these in the body. There are circumflex iliac arteries that wrap around the ilium and the pelvis. There are circumflex femoral arteries that wrap around the femur in the leg. So anytime you have an artery that wraps around something, it's called a circumflex. In this case, it's wrapping around the humerus, so it's a circumflex humeral artery. And there are 2 of them, an anterior one that wraps around the front of the humerus and a posterior one wrapping around the back of the humerus. So the anterior circumflex humeral artery typically is much smaller and would be going more anteriorly around the front of the humerus. And then the posterior circumflex humeral is typically larger and would be wrapping around the back of the humerus. You may not remember it, but you've already seen, or should have seen, that posterior circumflex humeral artery, because it's one of the structures that passes through the quadrangular space and ends up in the back of the shoulder on the deep surface of the deltoid muscle. It should be running right alongside the axillary nerve through the quadrangular space. All right, so those are the first 2 arteries or branches off the third part, anterior and posterior circumflex humerals. The final branch off of the third part is identified by the letter D here. This is the subscapular artery. And this is by far the largest branch of the axillary artery, or at least it's typically the largest branch of the axillary. And it's called subscapular, maybe for obvious reasons, because it's lying deep to the scapula or on the deep surface of the scapula. The subscapular artery itself may only be about 1 inch long, and then it's going to split again into 2 other branches. E is called the circumflex scapular artery. This is going to wrap around the back of the scapula, and this is going to pass through a different space called the triangular space in order to reach the back of the shoulder. And then finally, F here is called the thoracodorsal artery, and that's going to run down into the latissimus dorsi muscle, which would be coming up from the lower back in this area to insert on the intertubercular groove of the humerus. There's some other arteries shown up here that are not really part of the axilla, but I wanted to mention them. There are several branches that come directly off of the subclavian artery before the subclavian changes names to become axillary. One of these is called the vertebral artery. We won't see that yet. We'll see that later in the course a couple different times. Just an interesting fact, though, is that the vertebral artery is the structure that passes through those little holes in the transverse processes of the cervical vertebrae. Remember, all of the cervical vertebrae are distinguished by having something called a transverse foramen, the little round hole in the transverse process. So it's this vertebral artery and its accompanying vertebral vein that are running through all those little holes in the cervical vertebrae. Just lateral to the vertebral artery is a little short trunk called the thyrocervical trunk. That is often very short and gives rise to several branches. There's an inferior thyroid artery labeled A, bringing blood to the thyroid gland. We'll see that later when we dissect the neck. The transverse cervical artery labeled B. You may not realize it, but you've already seen that also. If you explored the deep surface of the trapezius muscle after you reflected it, you were supposed to look for the spinal accessory nerve, one of the cranial nerves that innervates the trapezius, that spinal accessory nerve is sitting on the deep surface of the trapezius, and this transverse cervical artery is running right next to it. So this is coming from up here in the neck, from the thyrocervical trunk, and working its way back towards the back to eventually lie on the deep surface of trapezius. And then the final branch here is another one that you've seen and may not realize it. The artery labeled C is the suprascapular artery. This is also heading towards the back of the shoulder, and this is the artery that crosses over that ligament over the scapular notch and eventually goes into the supraspinous fossa to supply blood to muscles like the supraspinatus. And then from there, it continues down to the infraspinatus. So many of you have seen this artery. In some cases, I don't think the body had it or it was already destroyed, but I think many of you actually were able to see this artery going over that little ligament when we did the posterior shoulder dissection. All right, let's see here. So here on the back of the shoulder, we can see a few of those vessels and nerves and things that we were just, well, we haven't talked about the nerves yet, but you can see some of the vessels. So you see that scapular notch and that little ligament that covers the notch up on the superior border of the scapula. And there's a suprascapular nerve that goes under that ligament, and the suprascapular artery crosses over the ligament. And then from there, the artery and nerve continue through something called the spinoglenoid notch to get into the infraspinous fossa, where the infraspinatus muscle is. And then if you look at the square object, that's the boundaries of the quadrangular space, where you see the axillary nerve passing through to get to the deltoid, and the posterior circumflex humeral artery, one of those branches from the third part of the axillary. So they're coming together through that quadrangular space. And then finally, you see the triangular space with that circumflex scapular artery passing through. Right, the other really important structure located within the axilla is the brachial plexus. And this is the nerve supply to the entire upper limb. So all of the muscles in the upper part of the arm, the forearm, and the hand are all innervated by this, and also even a lot of the superficial back muscles and the pectoral muscles are also all innervated by branches of this brachial plexus. It's a rather complex structure, but you should know the pattern of it. So let's talk about the pattern of the brachial plexus, and we'll start off with just this simple schematic view. So first of all, the brachial plexus is made up of the ventral rami of 5 of the spinal nerves. So remember in Tuesday's lecture, we talked about the spinal nerves, how these are nerves that are exiting the intervertebral foramina, at every vertebral level of the vertebral column. They're branches directly off of the spinal cord. And after the spinal nerve exits the intervertebral foramen, it immediately splits into a dorsal ramus and a ventral ramus. The dorsal rami are just supplying things like the deep back muscles, and they're responsible for sensation from a narrow area of skin down the midline of the back. The ventral rami do everything else. They supply the skin in the rest of the back, lateral to the shoulder blades. They innervate the skin of the whole thorax and abdomen, as well as supplying all the muscles and all of the skin in the limbs. So from C5 down to T1, those ventral rami of spinal nerves join together in a very specific pattern. They split apart and then join together again and split apart again and then join together again in this very complex pattern. But this pattern is fairly consistent between individuals. So we've got, as I said, we've got these different ventral rami. The ventral rami of C5 and C6 are going to join together to form something called the superior trunk. And it's named for its position, the fact that it's superior, it's closer to the head. The ventral ramus of C7, all by itself, is known as the middle trunk. And then finally, the ventral rami of C8 and T1 join together, so that's the first thoracic spinal nerve. They join together to form the inferior trunk. Again, named for its position, this would be more inferior, closer to the feet. The three trunks of the brachial plexus then split apart into what are called divisions. And each trunk splits into an anterior division and a posterior division. So you look here, you can see the superior trunk splitting into an anterior division going this way, and then a posterior division going back that way. Middle trunk also splits into anterior division, posterior division, and inferior trunk does the same, posterior and anterior divisions. These
Just
divisions,
a question. Oh, sorry.
yeah, go ahead.
I don't. Why for the inferior divisions? Why is the anterior one below the posterior one?
Oh, so the divisions are called anterior and posterior divisions, and those are divisions of the three trunks. So you start off with the three trunks, which are named for their position. So you've got, superior trunk at the top, middle trunk in the middle, and inferior trunk at the bottom. Then each of those three trunks is going to split into anterior and posterior divisions. So the fact that the posterior division is above the anterior division of the inferior trunk, that doesn't matter. It's all still inferior to the other trunks. Does that make sense?
Kind of, yeah.
Okay. So the divisions then come back together in a very characteristic way to form a series of structures called chords. And the three chords are named for their position relative to the axillary artery, because these three chords are surrounding the axillary artery on three sides. Now, when you look at the names of the chords over here, you look at the names lateral, posterior, and medial. Boy, that lateral one doesn't really look lateral. It looks more superior, and the medial one looks more inferior. But what you have to imagine is that in this particular schematic view, the upper limb has been abducted relative to the body. So the upper limb, is extending out like this in the abducted position. So it's been rotated up. So the chords are kind of lying in this position. But if you imagine the body being put back into anatomic position, where the arm is at the side of the body, now those three chords are going to be more, lateral away from the body and medial towards the body. So the schematic, we have an abducted arm, so these things kind of change position. But the lateral chord is made up of the anterior division of the superior trunk plus the anterior division of the middle trunk joining together. The medial chord is formed from just the anterior division of the inferior trunk. Nothing else joins it. And then the posterior chord is made up of the posterior divisions of all three trunks coming together posterior to the axillary artery. The three chords then eventually split into what are called terminal branches. So lateral chord terminates here where it splits into these two branches. Medial chord terminates here where it splits into these two. And then posterior chord terminates here where it splits into those branches. Now notice that in addition to those terminal branches, where the chords actually end, there are other branches found throughout different parts of the brachial plexus. So there's this branch and that one, and there's a couple little guys up here, and one branch over there, and some more coming off the posterior chord, and some others over here off the medial chord. So there are small branches coming off several places throughout the brachial plexus, in addition to the very large terminal branches at the very end. So let's add some more detail on here. And I got to get rid of my, all right, there we go. So now you see that branching pattern of the brachial plexus along with the names of all of the branches. And you're going to be seeing most of these in lab today. And you should try to identify these in lab today. There are a few that you won't be able to see. And I'll describe those for you. So just to go over the pattern again quickly, you've got ventral rami from 5 of the spinal nerves. The ventral rami of C5 and C6 join together to form the superior trunk. The ventral ramus of C7 by itself forms the middle trunk. The ventral rami of C8 and T1 join together to form the inferior trunk. Each of the 3 trunks then splits into anterior and posterior divisions. Those divisions come back together and rejoin in a different pattern. So the anterior division of the superior and middle trunks together combine to form something called the lateral cord. The anterior division of the inferior trunk all by itself is called the medial cord. And then the posterior divisions of all 3 trunks join together to form the posterior cord. And again, those 3 cords are named for their position relative to the axillary artery, but when the arm is held in the fully adducted position against the body, they would really be, truly medial and lateral and posterior to the axillary artery. So the branches of the brachial plexus include, there's a dorsal scapular nerve, which is actually coming directly off the ventral ramus of C5. You may not remember it, but if you've started studying at all, you may be aware that the dorsal scapular nerve is the nerve that innervates the levator scapulae and the 2 rhomboid muscles. There's also a nerve here that's actually formed by contributions from the ventral rami of C5, C6, and C7 joining together, called the long thoracic nerve. This nerve is going to run down the side of the chest on the surface of the serratus anterior muscle. So this is one you'll probably be able to see today. By the way, you won't be able to see dorsal scapular nerve today. It's too high up in the brachial plexus and we can't see that part of the plexus. But you will see long thoracic nerve, or at least you should see it running along the serratus anterior. This is the nerve that innervates the serratus anterior muscle. Suprascapular nerve branches directly off the superior trunk. You won't see that coming off of the brachial plexus today because, again, it's a little too high up in the plexus. We're not going to see the upper part of the plexus today. But you have seen that nerve before because that's the one that passes under that little ligament to supply the supraspinatus and infraspinatus muscles in the posterior shoulder. There's another little nerve coming off the superior trunk, which is the nerve to the subclavius, which innervates just the subclavius muscle under the clavicle. We get down into the cords, and there's a bunch of branches coming directly off the 3 cords. There's only one branch coming directly off the lateral cord. That's called the lateral pectoral nerve. This is going to enter into the clavicular head of the pectoralis major, and it's part of the innervation of pectoralis major. Over on the medial cord, we have a medial pectoral nerve, which is going to pass through the pectoralis minor, innervate the pectoralis minor, and then continue into the pectoralis major, where it also innervates part of the pectoralis major. I want to make a point about these medial and lateral pectoral nerves. You should have been looking for them as you did your pectoral region dissection. As you were reflecting the pectoralis major muscle out of the way, you may have encountered these. I don't know if you identified them or not, but you may have encountered them. I know some of you saw the medial pectoral nerve actually piercing through the pec minor and continuing into the major. But what you may have noticed about these nerves, if you did see them, is that the names seem strange when you see the relative position of them. The medial pectoral nerve actually sits more lateral in the body. The lateral pectoral nerve sits in a more medial position on the body. So where in the world are the names coming from? They're named according to which cord of the brachial plexus they're coming from. They're not named according to their position in the body. They're named because of which cord of the plexus they're coming from. A couple of other branches off of the medial cord, which are numbered here because I couldn't fit the names in next to the branches. There are a pair of cutaneous nerves. Sometimes when you see the word cutaneous, well, the word cutaneous means skin. And so oftentimes when you see the word cutaneous in a nerve, it means that it's a sensory nerve, that it's only responsible for sensation from an area of skin. That's not always the case, and I'll show you an exception in a minute. But the medial brachial cutaneous nerve, number 1 here, is a sensory nerve to the skin on the medial surface of the brachium. The brachium is the proper anatomic term for the upper part of the arm. So the region of the arm between the shoulder and elbow is known as the brachium. So the skin on the medial surface of the brachium is innervated by this number 1 here, this medial brachial cutaneous nerve. So that would be the skin of the upper part of the arm that's facing towards the body or in contact with the body. Number 2, the medial antebrachial cutaneous nerve is a sensory nerve to the skin on the medial aspect of the antebrachium. The antebrachium is your forearm. So if you imagine the upper limb held at your side in proper anatomic position, the pinky side of your forearm would be facing in towards your body. So that would be the medial aspect of the forearm. So there are also 3 branches coming from the posterior cord, directly from the posterior cord. There's an upper and a lower subscapular nerve. These 2 nerves together innervate the subscapularis muscle. The lower subscapular nerve also has a branch that wraps around the back of the scapula to innervate the teres major muscle. And then in between those 2, number 3 here is thoracodorsal nerve. This is the nerve supply to the latissimus dorsi muscle. And finally, we get out to the terminal branches. These are the large branches where the 3 cords end. And this is the last point where they split, and they remain separate from this point down. The lateral cord terminates here, where it gives off the musculocutaneous nerve and part of the contribution to the median nerve. The musculocutaneous nerve is a nerve that innervates both muscle and skin. So the musculo part is referring to the fact that it's a motor nerve supplying some muscles. Specifically, it's supplying all of the muscles in the anterior aspect of the brachium. So that would be things like biceps brachii, brachialis, and another muscle called coracobrachialis. So it's innervating those 3 muscles, but then it continues past those muscles as a cutaneous nerve, a sensory nerve, and it's responsible for innervating skin on the lateral aspect of the antebrachium or lateral forearm. So again, if you're holding your upper limb in anatomic position, this would be the thumb side of the forearm, would be innervated by this musculocutaneous nerve. Now, I said that the other terminal branch of lateral cord is a contribution to median nerve. The median nerve is receiving contributions from both the lateral cord and the medial cord. So you can see how there are branches coming from both of those cords that then join together to form the median nerve. The word median in this case, notice it's not medial nerve with an L, it's median with an N. Median means runs right down the midline. And this nerve actually runs right down the midline of the brachium and continues into the forearm as well and runs right down the midline of the forearm. It does a lot of stuff. It innervates a whole bunch of muscles in the forearm and a handful of muscles in the hand, no pun intended, a bunch of muscles in the hand, as well as being responsible for innervating some skin on the palm of the hand and the first 3 or 4 digits, the thumb, index, middle finger, and ring finger. You don't need to know much detail about these nerves because you're not going to see where they go, and you're not going to see the structures that these things innervate until we get a little farther along. Some of the other nerves you do need to know. So you should know things like dorsal scapular, long thoracic, suprascapular, because we've studied the muscles that these things innervate. You should know lateral pectoral nerve. In fact, you should know all of the branches that are coming directly off of the higher parts of the plexus. Lateral and medial pectoral nerves are innervation to the pectoralis muscles. Upper and lower subscapular nerves, supplying subscapularis and teres major, thoracodorsal nerve supplying latissimus dorsi. So these are all muscles that we've studied so far, so you should know these. But some of these terminal branches are supplying things that we haven't studied yet, so we'll get to those later. So like musculocutaneous nerve, I said it innervates the 3 muscles of the brachium. Well, we haven't studied the brachium yet. We won't get to that until after the exam. So you don't need to know really what musculocutaneous does. And you don't really need to know what the median nerve does yet because we haven't gotten to any of those structures yet. Same thing with the ulnar nerve. The medial cord terminates by contributing to median nerve, but then it also splits off to form the ulnar nerve. The ulnar nerve runs down the medial aspect of your forearm and supplies just a couple muscles in the forearm, and then supplies a whole bunch of muscles in the hand, as well as some of the skin on the medial aspect of the hand. But again, we haven't studied the forearm or the hand yet, so you don't really need to know much about this nerve other than just know the branching pattern.
I have a question.
Yeah.
I think you already said this, but are we looking at this from a posterior view or anterior view?
Oh yeah, I didn't make that point. That's a very good point. This is an anterior view of the left brachial plexus.
Okay, thank you.
So the center of the body would be over to the left side of the slide, and the rest of the arm would be over at the right side of the slide. But yeah, that's good, very good point. All right, the last terminal branches that I want to mention are the terminal branches off the posterior cord, and this includes the axillary nerve and the radial nerve. Now, axillary nerve is another one that you should know because we've already talked about the structures that it innervates. It's going to pass through the quadrangular space along with the posterior circumflex humeral artery, and it's going to innervate the teres minor as it's passing through that space. And then once it finishes passing through that space, it's going to enter into the deep surface of the deltoid, where it's going to innervate the entire deltoid muscle as well. One thing we haven't talked about before is that there's also a cutaneous branch of the axillary nerve that continues right through the deltoid muscle into the skin over your shoulder. So essentially the skin overlying the deltoid is sending sensory information in through the axillary nerve as well. So it's another one that's a mixture of both motor and sensory neurons. And then the radial nerve, you don't need to know much about radial nerve because we haven't really studied any of the structures that the radial nerve innervates. It innervates muscles in the posterior compartment of the brachium, the posterior compartment of the antebrachium, so on the back of your forearm, and then is also a sensory nerve to some skin on the back of your hand. So we'll come back to that later. But you have seen the radial nerve at least once. When you were dissecting the posterior shoulder, you were also supposed to look into a space called the triangular interval between the long head and lateral heads of the triceps, brachii muscle in the back of the arm. And when you look in there, you can actually see this great big fat nerve crossing on the posterior surface of the humerus. That's radial nerve. You'll see radial nerve again in lab today when we finish up the dissection of the axilla. Here's my, oops, didn't mean to do that. Okay. So when I was talking about the brachial plexus, I mentioned a number of nerves that have sensory component that are responsible for bringing sensory neurons from the skin back through the brachial plexus and eventually back to the central nervous system, back to the spinal cord, so that you can sense, touch, temperature, and pain, and so forth. So things like the two cutaneous nerves coming off of the medial cord, these are sensory nerves. The musculocutaneous nerve has a sensory component to it, to the lateral forearm. The axillary nerve has a sensory component also that supplies skin over the shoulder. All of the other terminal branches, ulnar, median, and radial, also have sensory components to skin down in the hand. So it's possible to draw a map that shows the areas of skin that are innervated by each of these nerves. So if you look at the gray area up on the shoulder, you'll see that that's identified as axillary nerve. So what this is showing is the areas of skin that are innervated by the sensory branches of the axillary nerve. Below that is radial nerve, shown in pink. We haven't studied these areas yet, so I wouldn't expect you to know any of this, but radial nerve is responsible for sensory innervation on the lateral brachium, the posterior brachium, the posterior antebrachium, so the back of the forearm, as well as some areas on the back of the hand. The musculocutaneous nerve has a branch called lateral antebrachial cutaneous nerve. So this is the nerve that innervates things like the biceps muscle, but then continues down into the lateral aspect of the forearm to become a sensory nerve on the lateral forearm. So that green area on the lateral aspect of the forearm is supplied by a branch or continuation of musculocutaneous nerve. And then if you look over on the right side of the slide, you'll see the distribution of the medial brachial cutaneous nerve. That's a branch that comes directly off the medial cord, and the medial antebrachial cutaneous nerve supplying skin on the medial antebrachium or medial forearm. That's also a branch directly off the medial cord. And then when you get down in the hand, you see that median nerve, ulnar nerve, and radial nerve are responsible for innervating skin in different areas of the hand. So when you look at a map like this, you want to think back to this picture and say, okay, there's the axillary nerve coming off the posterior cord. So that supplies this area of skin shown in gray. Musculocutaneous nerve is supplying the area in green. You look back here and say, okay, there's the musculocutaneous nerve, which is one of the one of the terminal branches of the lateral cord. Now this map right here is different from another map that I showed you on Tuesday. And it may be confusing that there are these two different maps. On Tuesday, I showed you this, which is a dermatome map. The dermatome map is telling you if you took all of the sensory neurons that supply a certain region of skin and you trace them back through the various branches of the brachial plexus and trace them all the way back to the spinal nerves, back to the spinal cord, where would those sensory neurons end up? In other words, at what level of the spinal cord would they eventually end up, or what spinal nerve would they pass through to get into the spinal cord in the central nervous system? So for example, that purple area labeled C6, that is the C6 dermatome. So what this map is telling us is that all of the sensory neurons that are coming from that whole purple region of skin, from the shoulder, the lateral brachium, lateral forearm, and thumb, all of those neurons would be passing through different branches of the brachial plexus and ultimately ending up back at the C6 level. Now, what's confusing about this is that the dermatome map doesn't exactly match the sensory nerve map that I showed on the previous slide. So, take a look at that C6 dermatome, for example, and just try to remember, it includes the shoulder, the lateral brachium, lateral antebrachium, and thumb. And then look over here at this picture, and you see a completely different kind of map. So this map is telling you which of those named branches of the brachial plexus the neurons are passing through. But this map is not telling you where those neurons eventually end up when they finally get back to the spinal cord. So you can see there's some overlap here, so that, for example, look down at the thumb. Let me get my little annotation thing up here again. So if you look down here at the thumb, some parts of the thumb are sending sensory neurons through the median nerve, shown in yellow. The back of the thumb is sending sensory neurons through the branches of the radial nerve. The whole lateral aspect of the forearm is sending sensory neurons through the musculocutaneous nerve. Part of the brachium is sending sensory nerves through radial nerve again, and then also part of the brachium is sending sensory neurons through the axillary nerve. But eventually, all of these neurons, if you were to follow them all back up into the spinal cord, would all be ending up at C6. Because everything on the lateral aspect of the upper limb, including the lateral brachium, the lateral antebrachium, and the thumb, those are all sending sensory neurons back to C6. So the map here is just showing you which branch of the brachial plexus they pass through initially. The other map with the dermatomes on it is telling you, where do those neurons end up once they get back to the spinal cord. So let me back up to the picture of the brachial plexus and kind of walk you through what I'm talking about here, just in case it's not clear at this point. And I realize it's a confusing concept, so it may not be all that clear. But using that example of the thumb again, there are some sensory neurons that originate in the skin on the front of the thumb, the anterior aspect of the thumb, which would be traveling through the median nerve. So they would show up on that first map as being part of the median nerve. But then those neurons would be passing through this limb of the median nerve, through the lateral cord, through the anterior division of the superior trunk, and back to the ventral ramus of C6, and back to the spinal cord at C6. Meanwhile, there are other neurons, sensory neurons, on the posterior aspect of the thumb that would be passing through the radial nerve. So they would show up on that first map as being part of the radial nerve. But when those neurons come back through the radial nerve, they'd be passing through the posterior cord, through the posterior division of the superior trunk, back to C6.
I've got a question.
Yeah.
Why wouldn't it go to C5 as well as C8 and T1 if the nerves are connected?
So that's a great question. So there are sensory neurons in the radial nerve that do go all the way back to C5, to C7, to C8, and T1. But those would be coming from different parts of the upper limb. So the point I'm making right now is that if we're looking at just the C6 dermatome, which would be just the thumb, the lateral aspect of the forearm, and lateral aspect of the arm, all of those neurons are going to end up at C6, because that's the definition of what the C6 dermatome is. But the radial nerve would also be carrying neurons from different dermatomes, which would end up at different spinal nerve levels.
Okay, I kind of understand.
Okay. So, so we've got sensory neurons coming from the front of the thumb, again, the thumb being part of the C6 dermatome, but from the front of the thumb, they'd be coming through median nerve and eventually back to C6. From the back of the thumb, they'd be going through radial nerve and various branches back to C6. The lateral aspect of the forearm is supplied by musculocutaneous nerve. So you'd also have neurons going through musculocutaneous nerve, through lateral cord, anterior division of superior trunk back to C6. And then, let's see if I got any more colors here. The lateral surface of the shoulder, that area of skin is supplied by axillary nerve, but it's also part of the C6 dermatome. So those would pass through axillary nerve, posterior trunk, superior cord, back to C6. So the point here is that you have many different nerves that are all ultimately sending sensory neurons back to a specific level of the spinal cord, back to a particular dermatome. So if you look at the two maps that I showed you here, as I said, this map is showing you which branch of the brachial plexus the neurons are passing through. This map, the dermatome map, is telling you where those neurons eventually end up. So, for example, something that I could do on a laboratory exam would be to put a pin in a specific area of skin and ask you, number one, which dermatome is this? Number two, I could ask you, which sensory nerve is responsible for innervating this area of skin. So for example, I can figure out where my thing went here. All right. So let's say I put a pin in the skin on the lateral forearm right there. Well, I know that the entire lateral upper limb, the whole lateral surface of the upper limb, including the thumb, lateral forearm, and lateral brachium, that's all part of the C6 dermatome based on this map. But then if I can get to my other map. Oops. Based on this map, I know that that same area over here, where the pin is located, is part of the sensory distribution of the musculocutaneous nerve. So I would know that the sensations, the sensory neurons that are being stimulated by this pin would initially travel through the musculocutaneous nerve. But because this area is also part of the C6 dermatome, I would know that those neurons would be passing through various branches of the brachial plexus to somehow get back up to C6. Or another example of that would be if I put a pin in the tip of the pinky finger down here. That's part of the ulnar nerve distribution. I won't jump ahead to the next slide because that means I got to turn off my little drawing tools here. But so a pin here in the pinky, I would know that that's part of the ulnar nerve. Actually, I do probably have to get out of here for a second. The pinky, if you look on the dermatome map, is part of the C8 dermatome. So the class that I used to teach for physical therapists, this is something that we would require them to do, is we would put a pin in the skin in a certain spot, and we would say, trace the path of a sensory impulse from the pin back to its termination in the spinal cord. So the pin sticking in the pinky finger, well, I know that that's part of the ulnar nerve distribution because everything on the medial aspect of the hand, including the whole pinky, is ulnar nerve. But I also know that that's part of the C8 dermatome. because the C8 dermatome is responsible for skin on the whole medial aspect of the upper limb. So this would be a relatively easy nerve tracing question. They'd have to say, okay, that sensory impulse would travel through the ulnar nerve, through the medial cord, through the anterior division of the inferior trunk, through the ventral ramus of C8 back to the spinal cord at the C8 level. Because I know the starting point from my map, I know that that skin of the pinky is part of the ulnar nerve distribution. And I also know that that's part of the C8 dermatome. The thumb one is a lot harder because different parts of the thumb are supplied by different neurons, or by different nerves. Another one that's relatively easy is if I did put the pin in the skin on the lateral aspect of the forearm. I know that the lateral aspect of the forearm is supplied by a branch of musculocutaneous nerve, but I also know that it's part of the C6 dermatome. So in this case, I'd have to trace it from musculocutaneous nerve, through lateral cord, anterior division of superior trunk to ventral ramus of C6, so that that nerve impulse would get from its starting point in the lateral forearm back to its termination point in the spinal cord. This sort of understanding of the distribution of sensory nerves in the limbs, in the upper limb, the lower limb, and the body is really critical for neurologists who are trying to understand nerve injuries. Because let's say you had a loss of sensation from your pinky finger. That could be the result of an injury to the ulnar nerve itself. It could be the result of an injury to the medial cord, an injury to the inferior trunk, or even an injury to the C8 spinal nerve. An injury anywhere along that path would disrupt the flow of sensory neurons from the skin of your pinky back to the central nervous system. And we would know that it's not an injury at C5 or C7, because if there was an injury at C5 or C7, it would affect completely different areas of skin on the upper limb. So that's why this was important for physical therapists, because they're involved in that sort of diagnosis and treatment of nerve-related injuries that affect the musculoskeletal and nervous system. I promise I won't give you a nerve tracing question. I won't ask you to trace a path, a sensory stimulus from the, say from an area of skin all the way back to the central nervous system, because, you're not neurologists, you're not physical therapists, you don't really need that level of knowledge, but you should still have an understanding of which areas of skin are innervated by which of these named branches of the brachial plexus. You should still have an understanding of the dermatome map to understand it. These are areas of skin that send sensory information back to a particular level of the spinal cord, because these are the sorts of things you could be asked to illustrate. So you should be aware of those. So I think I mentioned this on Tuesday, that you should be able to, identify a particular dermatome. So I could still stick a pin in an area of skin, and I could ask you, which of the named branches of the brachial plexus is actually responsible for innervating this area of skin, or I could ask you, which dermatome is the pin sticking in, or I could ask you both.